So each bed we are going to see one ECG and decide what to be done. So that is a format of this program. Okay. So this is ICU rounds. So the initial 5 minutes, any patient with acute chest pain should be seen immediately. Whatever the situation he is in, whatever the OP he is in or hospital he is in, initial 5 minutes is very important. Any chest pain patient, be it atypical or typical, it will be seen immediately. Second, the duration, nature of chest pain is very important. The duration is very important to decide about your therapy. Hemodynamic status to decide what to be done immediately. Immediately ECG should be taken. I wanted to do two important clinical examination. Check all pulses and auscultate, especially murmurs of aortic regurgitation and mitral regurgitation. So this is the first 5 minutes you are supposed to do that. Many times what happens is the patient with chest pain will come and they will be sitting in the queue with the token and he will be seen after 1 hour or 2 hours. So that should not be seen. That's a thing. So history and chest pain. So history, the main important thing is whether the patient has got pain which is gradually increasing or pain is maximal at onset. Because the dissection pain is maximal at onset. Ischemic pain builds over period of hours and minutes. Careful clinical examination, inequality of pulses and AR is very important. Because all patients with chest pain, unless you see these clinical findings, you will miss dissection. Because dissection pain can also have ST elevation because of coronary dissection. So the patient will come with the chest pain with ST elevation because of coronary dissection. So the pain radiating to back and below umbilicus is a very important history because ischemic pain will never radiate below umbilicus. It is above umbilicus and below jaw. If you think you have a suspicion of dissection, always do a echo, transesophageal or CT before you thrombolize because thrombolysis is contraindicated in dissection. So if you think it's dissection, you should not thrombolize the patient. So any acute chest pain patient, you look for these things. So unless 1 or 2 cases may be dissection, but routinely if you have this clinical examination like this, you will not miss a dissection. So these are the differences of presentation of dissection and acute myocardial infarction. So thrombolysis is contraindicated, it is down here and we are not able to see. So this is the first ECG, the chest pain 3 hours. So look at the ECG. Right. The question I am going to ask in this ECG is, what will you do? Heparin, antiplatelets, thrombolize, neither, refer and relax. Thrombolize. So you thrombolize this patient. Right. So another patient with chest pain. The difference is what? Difference between first ECG and this ECG is what? So here, what you will not do? Heparin, antiplatelet, thrombolize, statins. So you should not give subliquid nitrate and wait. So that is the thing. So the right answer will be 2 and 4, what you will not do. So why we are not, the basic idea about the ST elevation and non-ST elevation MI is this. So what happens is, when an acute coronary syndrome happens, it is because of the rupture of the vulnerable plaque. The vulnerable plaque ruptures and a huge thrombus which is getting formed, which is the one which is producing the acute coronary syndrome. So it is not actually the plaque, it is a plaque rupture and thrombus. The difference between STEMI and non-STEMI are non-ST elevation situations. I will not say non-STEMI. Non-ST elevation situations is decided by the quantity and quality of thrombus. If the plaque ruptures and the thrombus which is formed, it is going to critically narrow an artery. And it is a thrombus which is rich in platelets. It's a white thrombus. The patient will present with non-ST elevation situation. Critical occlusion, white thrombus. So that is the next slide, you can see that here. Whenever the patient comes with acute chest pain, with a subendocardial injury, the injury is predominantly inside the wall of a myocardium. The patient will present with ST segment depression. So there are two informations when the patient presents with ST segment depression. One is critical occlusion and it is a white thrombus which is rich in platelets. That's why you don't thrombolize these patients. You give heparin, antiplatelets and restratify and do aortic coronary angiogram or maintain them on medical line of management. Whereas whenever the patient presents with acute ST elevation, it is a sub-pan injury or a sub-epicardial injury. The injury is predominantly at the outer layer of the myocardium